Yeah.
Dear friends, it's my pleasure to be with you. Then now I want Dr. Sabino, Luzzi, and Albert Sufianov to moderate first section for surgery for intraventricular tumors. I leave the stage to Dr. Albert and Dr. Sabino.
Thank you. Thank you so much. Thank you once again for this very kind, organization of this beautiful event. And thank you so much for this kind invitation to Professor Zileli once again. And today we have a special guest. Thank you once again from all of us to Professor Sami and for his contribution. It's very important for all of us, especially young neurosurgeons. And today the first session will involve the surgery on intraventricular tumors. And we will have three very well-respected and worldwide known speakers. The first one is my friend Juan Villalonga from Argentina that will speak about ventricular anatomy. And the second one will be Professor Atul Goel from India. He requires no presentation. He will talk us about open surgical techniques for intraventricular tumors. And then the last speaker is from UK, Dr. Basel Zebian, that will talk about endoscopic approaches to intraventricular tumor. Thank you so much once again to all of you. And also thanks to my colleague, Professor Albert Sufianov here. And I leave you the stage to Juan Villalonga. Go ahead, Juan. Thank you.
Thank you, Sabino. Good morning.
Записать можно? Не, записать всю сессию.
Да, я хотел запустить.
Давай записать.
Can you see?
Yeah, it's okay.
Yeah, perfect. You can start.
Thank you. Good morning. My name is Juan Villalonga. Thank you for the organizers. First, my presentation. I'm training 15 years, 7 in Tucumán, in the northwest of Argentina, 7 in Buenos Aires, and after I did a sub-specialization in neuroendoscopy in Naples, Vienna, and Ohio. After return to Tucumán in my homeland, and in the last 5 years, I developed the neuroendoscopy, a system that I call the total neuroendoscopy. But, in the topic of this morning, ventricular anatomy. About the lateral ventricles. This is a sagittal cord of the brain. Can I observe? Can I observe the frontal horn, the body, the atrium, and the temporal horn? This is the lateral ventricle in C form. Different entry points to the ventricle. This is in the bone plane, the Coher point, and this is the entry zone in the ventricle. This is the Kaufman, more anterior, and Kaufman. Después tenemos the pain, Menowski, not useful, tabs, and this is anatomy in practice. A woman, a very young woman with headache. This is the preoperative MRI with tumor in lateral ventricle. This is the tumor in sagittal plane. And the anatomic question is, what ventricular entry point used in this case? I select the Coher point, and this is the Coher point in the bone plane, and this is the Coher point in front of foramen of Monroe. This is in the surgical position. I use a system port and endoscopic technique. This is remove the tumor through the port, a very blood tumor, and this is the Monroe free of tumor. After I open the septum, and this is the tumor in the left side. The pathologies reveal a subependymal giant cell astrocytoma, the pre and post MRI, the pre and post MRI without tumor, the patient without deficit. This is anatomy in practice. Atrium. This is the atrium, and can I observe the atrium after remove the choroid plexums? The choroid plexus in atrium is very important structure, and I mean exist different entry points. The key point is very useful. I used to put the proximal catheter in shunt ventricular atria or ventricular peritoneal shunt. A variant is the Frazier point, Dandy, Sanchez. And another very important tips are the transsulcal parafascicular surgical corridors. In this case, to approach the atrium, the intraparietal sulcus is very important. This in red is the intraparietal sulcus. There are the specifications, and this is a clinical case with anatomy in practice. A woman, 66 years old woman with acute confusional syndrome. And this is the preoperative MRI with an epidermal tumor in the right atrium. And this is the patient in position, semi-sitting position. I use the intraparietal sulcus with a keyhole approach, a very little approach, and a handmade port with neuronavigator to approach the atrium ventricularis. And this is the intradural state, remove the epidermal tumor, very, very easy. And this is the ventricular vision after the resection, the postoperative MRI without tumor, and temporal horn. This is the temporal horn in a sagittal view, and this is the temporal horn in a coronal view. A very important relation is a medial to temporal horn. Can I view the temporal, mesial temporal region with amygdalinous nucleus and hippocampus? Anatomy practice, a young boy with refractory epilepsy with 20 seizures per day. And this is the preoperative MRI with a genesium of corpus callosum and indirect signs of scleral mesial temporal region. And this is the patient in the operating room. Can I have the fission silver, the zygoma, and this is the incision in form to S, italic S, the keyhole craniotomy, and this is a very little craniotomy of 4 centimeters. And the intradural stage, we can observe the Sylvian fissure vein. And now work in temporal lobe after to open the temporal horn, and this is the choroid plexus, the amygdalinous nucleus, and hippocampus. And after to resect this, can I observe the vessels in crura and quadrigeminal synstern, and this is the tentorial free of amygdala and hippocampus. The pre and post neuroimaging, the pre and post neuroimaging, and the patient evolved without seizures and without neurological deficit. Third ventricle. This is a sagittal view of the third ventricle with the Monroe like to enter the third ventricle and the aqueductus of Sylvius. And this is an upper vision after open the roof of the third ventricle. Can I observe the mammilar bodies, the tuber cinereum, imprint of chiasm, and entry to aqueduct of Sylvius. And this is a down vision, external down vision to the floor of the third ventricle. This is the mammilar bodies and pituitary stalk. Well, the Monroe foramen, this is the entry to the third ventricle. This is the Monroe foramen and the entry to the third ventricle. And this is another tips Anatomic tip, very important, the lamina terminalis, and a structure anterior to superior in the third ventricle. We can use to evacuate or to drain a CSF leak in a surgery. And two very important structures in direct relation with the floor of the third ventricle are the Liliequist membrane with diencephalic and mesencephalic membranes, and the basilar artery. The basilar artery is very near to the floor or in direct contact with the floor of the third ventricle. Can I observe an endoscopic view after fenestration? This is the basilar artery very near to the floor of the third ventricle. And the most common surgery of the third ventricle is the third ventriculostomy. This is the operating room view previous to the ETV, and I perform a little incision. This is the entry point, modified Kocher point, and this is the anatomic prepared with cadaveric specimen with this is the coronal suture, and we can observe the direction. I thought the Kocher point in front of foramen of Monro. This is the direction to the approach to the lateral ventricle. This is inside to the right lateral ventricle, foramen of Monro. Through the foramen of Monro, we can enter to the third ventricle. This is the vision in ETV, mammular bodies, premammular space. This is a basilar artery. And after the fenestration, this is the final view. Fourth ventricle. This is a sagittal curve to the intracranial, the brainstem, the cerebellum, and this is the fourth ventricle with aqueductus Sylvius and Sylvius aqueduct, and this is the outlet of the fourth ventricle. This is the floor of the fourth ventricle, and this is the roof of the fourth ventricle with velo medullaris superiores or valvula tarim, velo medullaris inferiores or valvula debussans. And we imagine that we disconnect the cerebellum and turn the brainstem. We can observe the floor of the fourth ventricle like a rhomboid. The superior triangle is protuberance triangle, and inferior triangles a bulbar triangle. This is a very, very, very eloquent area with functions to facial, ocular movements, audition, and deglution. A very eloquent area. This is anatomy in practice, in operating room. A man, the 64 years old, the uncle of my wife, the patient, with a lot of autonomic symptoms, present this cyst in protuberant cyst. This is a neuroenteric cyst. This is the patient in position, and we can observe the view, endoscopic view of the floor of the fourth ventricle. The anatomy is different, and this is the zone or the area of the cyst. And first punction, and this is cyst bulging, aspiration, and after is the vision. After the aspiration, we recover the normal anatomy of the fourth floor, and this is a aqueduct of Sylvius. After of this is stimulation, and new stimulation open the floor of the fourth ventricle in a not eloquent point, and after resection of the cyst. A very little videos, okay? In the first, the stimulation of the floor, after the bulging of the cyst, the aspiration, and this is remove the cyst. The pre- post-operative MRI and the patient without neurological deficit and without autonomic symptoms. This is the preoperative and post-operative. In conclusion, the surgical anatomy is the cornerstone for the practice of the total neuroendoscopy. Thank you.
And John, Juan, thank you very much. Excellent presentation. Hear me?
Sí. Okay.
Dear Professor Villalonga, thank you very much. Excellent presentation.
Thank you.
Thank you for the presentation. And of course, one of the most important is ventricular anatomy for this kind of surgery, because the space is very restricted during the surgery. So the landmarks inside of the ventricles is most important for orientation. It doesn't matter open surgery, endoscopic surgery. For endoscopic surgery is most important, for example, but even for open surgery, the landmarks inside is very important. And we know very well the ventricular system is very complex. It's a very complex system. And your right weight, you divide for the lateral ventricle one anatomy, and the third ventricle another, the fourth is another word, and so on. So thank you very much. And I think your presentation gives a lot of knowledge for the young neurosurgeon, and your combination with the anatomy of the life surgeries cases is very interesting. Thank you very much. It's my opinion.
Well, thank you, Professor Sufianov.
Okay. Good wishes to Argentina.
I think now we can